Is that cool?
Yep, absolutely. So this one is a really interesting case. This is from Dr. Stavros Karacozis. That is a real-life problem that we deal with every day. The bottom line is it's going to be a diffuse sclerosing variant in a teenager that has persistent positive antibodies. So this is a 17-year-old. You can see the diagram there on the left with all of the dots that even an endocrinologist recognizes as probably a bunch of lymph nodes all over the place. We refer to that as in the neck. You guys divide it up. We don't. Goes to surgery, and no surprising, bilateral multifocal papillary cancer, diffuse sclerosing variant, bunches of lymph nodes on both sides of the neck up to about 2 centimeters or so, some mediastinal lymph nodes. And now after surgery, not surprisingly, it has thyroid globulin antibodies, and the question is going to be, how do we do follow-up? Dana, for the ones of us that don't do surgery, as soon as you hear about diffuse sclerosing variant and doing surgery on a diffuse sclerosing variant, what are you thinking about? Is it going to be sticky? Are they going to lymph nodes? What do you expect?
I'm gonna block out a lot of time in the OR. That's for sure. Just make sure I got plenty of time to go. It's kind of like Easter egg hunting. You know, you've got the lymph nodes like everywhere, and they're behind stuff, and they're just everywhere. So you really have to be very careful. And I want to congratulate you on this very, very nice lymph node map. This is very, very important for every kind of thyroid cancer, particularly for young patients. Huh?
We love this map.
Yeah, no, this is very, very good, and this is what we get. This is what I would ask for. And I would probably, with this mass kind of, I don't know if that's the thymus that they see in the ultrasound, I would probably get a contrast enhanced CT scan on this patient preoperatively as well. I'd look at the vocal cords too, because sometimes these are locally invasive. But yeah, this would be, they're mostly resectable. I'd be aware of maybe the right vocal cord. It might be, the right recurrent nerve might be encased, and I would definitely tell the patient that there is this risk, enhanced risk. But this is going to be a long surgery with comprehensive bilateral neck dissection.
So, Rich, what are the expectations you set after surgery? I mean, you and Dana have spent hours in there operating. You come out to the waiting room and do the usual. I got it all. What are the expectations you're going to tell the family in terms of what to expect here?
The usual, I got it all. Is that what he said? Did he say that?
The patients always say when they wake up, "Did you get it all?" And then you have to reprogram them. That's the wrong way to talk and to think, especially for a 17-year-old where the parents are going to be all over you. For these pediatric cases, you have to spend a lot of time with the parents and set the expectation that the thyroid globulin is not going to become undetectable. And if they have antibodies, then the antibodies don't become undetectable. Whatever marker you're using, for medullary thyroid cancer, the calcitonin will not become undetectable. You set that as an expectation. And if they do become undetectable, then you look like a hero. But you have to prepare them for this. And you also prepare them for microscopic residual that you may be unable to image and identify. You prepare them for the possibility of distant disease becoming apparent at a later state. I usually image these people with neck and chest CT up front so that the little lung nodules they know about already, and you tell them, we know about this, we're going to rely on the iodine, and we're going to track this, et cetera, et cetera. But setting the expectations is essential. But these diffuse sclerosing in the pediatric population can be quite challenging, and in my experience, it's much harder to get durable control of disease in this population.
Mike, actually, these patients need to be prepared before the surgery also, knowing the extent of the disease. Yes, they are going to ask you on the day of surgery, did you get it all out? But they are well prepared that she is unlikely to be 100% cured. She will come back in few years with another lymph node, and we're not going to push you into surgery. We're going to monitor, see what happens. So their expectations are with us.
Yeah, I can always tell when the expectations are set right. When 6 months later there's still a little lymph node or it's not going away, and the family says, "Is this what you were talking about before? Is this what that we might see?" Sophie, go ahead, Dana.
So, Mike, these lymph nodes all over the place, and we can be as extensive as we can try, and we look, like I said, but there are hidden lymph nodes like all over the place. So it's really tough. It's tough for us. So be kind, please.
I completely defend you guys. One of the things that I say is surgeons are good, but they're not God. You know, sometimes they...
The endocrinologists are the gods.
Sophie. Roll a radioactive iodine and diffuse sclerosing variant. We're definitely going to give it. Does it work? Does it help? What do you think?
Yeah, I think it works.
That's encouraging.
No, it works. It works when there's residual small lymph nodes that can be totally cured with radioactive iodine. It works when you have lung metastasis. You can have you can cure the lung metastasis. What you don't, or what you really rarely do, is that you don't normalize thyroglobulin, or in many cases you don't normalize TG antibodies. But I think that thyroid cancer, pediatric thyroid cancer, is something really special, even if they have lung metastasis, because every time you read all the articles, you need to get in your head that they don't die from thyroid cancer in most of the cases, even though they have diffuse lung metastasis. And this has to be said to the patients. It's gonna be a long chronic disease, maybe, but they won't die from it. And in many cases, they can have quite a normal life. Yeah. So yes, I will do radioactive iodine. I don't know if it...
So would we, I just kind of want you to defend your job. Fernanda, teenager, diffuse sclerosing, chest CT didn't show anything. She got 150 millicuries radioactive iodine, has positive antibodies. What does your follow-up look like over the next sort of year? We can't do it forever, but what would that look like help out Dr. Karacozis here?
First, I would like to, I couldn't help noticing that she has Graves' disease in the past. So this is something that I think you should worry about when you're doing radioactive iodine to her. Like, take a look at her eye. How is she doing? How is her PSI levels? As Sophie just said, she's going to live forever. So we don't want her with something caused by radioactive iodine without protecting her eyes. So this is something that it just called my attention.
We have a little follow-up in the question and answer. The person who submitted this case says the most recent ultrasound is clear. Means the surgeon must have been very, very good. And also, we have a question from Dr. Menendez asking about, would anyone consider external beam radiation after surgery with extensive nodal disease like this?
Hey, Chuck.
Laurie,
No. Absolutely no. This is not the time to consider external radiation therapy in this patient. If you give external radiation therapy, number one, it will not help much. It may help you a little bit, but more importantly, she is 17. She's going to have radiation-related problems, and probably 10%, or I don't have number, but a fairly serious number of developing radiation-related tumors. So don't think about it at this time.
Absolutely. Okay.
Can I jump in and say one thing? So I'm tainted, of course, because all I see are patients with advanced thyroid cancer, and so these pediatric patients do well. But she's going to want to live until she's 80, and so I do think that there is a risk of patients with pediatric disease that doesn't completely go away to progress in a clinically meaningful way over decades. One thing that I hope that we'll have a role for in the near future is genotyping these patients. So pediatric patients have about a 50% rate of harboring now potentially actionable fusions, RET fusions and NTRK fusions. And I think that we're seeing that there's a possible emerging role for combining treatment with NTRK inhibitors or RET inhibitors with radioactive iodine to really get a more robust uptake of RAI in these patients. And NTRK is not...
Asked that exact question about the role of RET inhibitors.
Yeah, so we will be doing a clinical trial investigating the role of a RET inhibitor along with radioiodine in patients with RET fusion positive thyroid cancer. And I was just going to say, NTRK is probably too rare for us to really be able to do a clinical trial, but hopefully we'll even be able to study that in clinical trials in the future.
Mike, we have one related question which is similar to this, but Dr. Anderson asks, total thyroidectomy 10 years ago for PTC, also had RAI afterwards. All imaging study is negative, but TG is slowly rising.
Yeah, not an uncommon scenario, right? So it's usually small volume, well differentiated thyroid cancer, often small volume lymph nodes. Ian Hay years ago said nobody ever died of a thyroglobulin, so we don't treat thyroglobulin numbers. But depending on the rate of rise and how high it gets, it guides your imaging. So you just got to keep chasing the neck and the chest every once in a while.
So, Rich, if you as a surgeon are sent such a patient with no localizable disease but an elevated TG, should you do an empiric lateral or central neck dissection?
No, I do the ultrasound first, and then I'll do like a high resolution CT neck and chest and look at the whole landscape and look for targets. And then sometimes we'll just track the TG, see what it does dynamically, and take it from there.
Empiric lateral or central neck?
Let's finish with Dr. Karakos's question. There you go, Jayden. I think you're turned on, Jayden. Can you go on mute? Fernanda, let's finish up his question. So we've talked about the prognosis. We think she's probably going to do good, have persistent disease. We wouldn't be surprised if she was a RET PTC fusion because those are common in diffuse sclerosing variants. You can charge for the consult because he now gave you a follow-up that the repeat ultrasound is good. So we'll do the billing later. But what would your follow-up look like over the course of this next year?
I think we already said that she's going to do well. So we have to avoid unnecessary testing, unnecessary anxiety for this family. She had a very bad disease to begin with, but when I get the feeling here that she got like a biochemical incomplete response afterwards. So maybe we can follow the trend of antibodies, and every once in a while get an ultrasound, knowing that she can have false positive because she has autoimmune disease. So maybe do not value the lymph nodes that you said that you find, and she probably would do very well. So I would basically follow her with labs and see how it goes from there.
Very good. All right, Greg, you want to go on to number 5?
Yeah, I think maybe we'll just do 5 and then